Hello, everybody. I'm Salim, and today we will be speaking about our human pathology clinical research project. So, the overall project objective of this was to learn and understand how to manage a clinical case. So, how do we dissect it and try to pick out some information from it to create possible diagnosis, and learn how to use that diagnosis to further understand the situation, things of options of treatment, etc. So, the first question that came up on this was based on the clinical history and physical examination, what could be your differential diagnosis? So, first thing, let's address some of the clinical findings that we found in the patient. Some are respiratory distress, cardiac concerns, hepatic fluid retention issues, arrhythmia, renal dysfunction, gastrointestinal findings, metabolic disturbances, and some family medical history. Now, with all of these clinical findings that we got, some of the potential diagnoses that we could consider is due to the signs of heart failure and exacerbation with pulmonary and hepatic congestion, we can consider acute or chronic heart failure. Another thing would be due to the renal dysfunction indicated by the elevated creatine and blood urine nitrogen levels, we can also put in chronic kidney disease as an option. Another thing is that due to the patient's low hemoglobin and myrokitic anemia, we could also put in anemia of chronic disease or iron deficiency anemia as an option. Another thing which can come from her family history or due to the fact that positive stool occult blood tests and suspected growth in the right colonic apex, we could also add in colon cancer as another option. And for the last diagnosis that we could consider due to the clinical findings that we had, another stool occult blood test and potentially linked to colon cancer, we could include gastrointestinal hemorrhage.
From what we saw from the case, there were many different abnormalities that were seen, and that includes severe anemia, which can be seen by the iron deficiency that was shown, kidney dysfunctions due to the creatine levels being 176 U-mol and the BUN being 24.3 L-mols. Metabolic association as well, which occurs due to the impairing kidney functions, as well as cardiovascular issues due to the BNP being low, as well as placing a strain on the heart. Lastly, digestive tract cancer could also be a factor since cardiac abnormalia was found and requires urgent treatment. And a need to focus on managing the heart failure, improving the kidneys functions, treating severe anemia, incorporating cancer therapy, and closely monitoring over the health. Second slide. Possible diseases and possible diagnosis and diseases. The possible diagnosis of disease in this case could be one of them is that the patient has shown heart failure symptoms like dysophania, lithograde, and rolls at the lung basis. Secondly is anemia, which is shown by the low levels of hemoglobin in the blood and the higher levels of MCV in the cardiac diseases, causing cardiac diseases. Third being cardiac abnormalia, shown by the positive occult blood in the stool. Lastly, compressed metabolic acidosis, which is shown by the pH being imbalanced.
Hi, my name is Adam, and I'm going to explain the pathophysiology of colon carcinoma. So, colon carcinoma, or colorectal cancer, begins in the cells lining the colon or rectum. It starts with genetic changes that make cells grow abnormally, forming polyps. These polyps can grow and turn into cancer over time. CRC develops slowly, beginning as benign polyps. These polyps can become cancerous through a series of genetic changes. The first change usually happens in the APC gene, which controls cell growth. Initially, these polyps are non-cancerous, but as more genetic changes occur, especially in genes like TP53 and KRAS, the polyps become precancerous. These changes allow the polyps to invade surrounding tissues. When the polyps invade deeper tissues, they turn into cancer. The cancer cells keep changing, allowing them to avoid cell death, grow uncontrollably, and spread to other parts of the body. Chronic inflammation, like in inflammatory bowel disease, can make this process worse. Inflammation creates an environment that helps the tumor grow and get more nutrients and oxygen. Diet and lifestyle also play a role. Eating a lot of red and processed meats, low fiber intake, smoking, and not exercising increase the risk of colon cancer. Genetic factors are important too. Conditions like Lynch syndrome and familial adenomatous polyposis cause early and multiple polyp formation, speeding up the cancer development process. Colon cancer has many causes: genetic changes, environmental factors, and inflammation all work together to turn a benign polyp into cancer. In conclusion, colon carcinoma involves a mix of genetic, environmental, and inflammatory factors. Understanding this helps us better prevent, diagnose, and treat this cancer. Next, what are the laboratory investigations used to diagnose colon carcinoma? So the initial step involves a complete blood count to detect anemia, often indicating iron deficiency due to chronic blood loss from the tumor. Carcinoembryonic antigen, CEA, levels are checked. Although not specific, elevated levels can suggest colonic cancer and guide further testing. Stool tests such as fecal occult blood tests and fecal immunochemical tests are conducted to detect hidden blood, a common indicator of colorectal cancer. Colonoscopy allows direct visualization of the colon and rectum to identify and biopsy suspicious lesions, providing a definitive diagnosis. During biopsy, tissue samples are collected and examined in the lab to confirm cancer presence, determine its grade and stage, and inform treatment decisions. Next, imaging techniques like PET, MRI, and CT scans are used to assess tumor spread to nearby lymph nodes and distant organs, crucial for treatment planning and prognosis. So, in conclusion, a combination of blood tests, tumor markers, stool tests, colonoscopy, and imaging tests plays a vital role in diagnosing and staging colonic cancer, including effective treatment strategies.
And today I will explain about the form of anemia in this patient and describe the etiology. Okay, basically this patient has macrocytic hyperchromic anemia as indicated by laboratory results showing the low hemoglobin, hematocrit, mean post-pulmonary volume, and mean post-pulmonary hemoglobin levels. This form of anemia is characterized by red blood cells that are smaller and paler than normal, reflecting a hemoglobin deficiency. The most common cause of this anemia is iron deficiency, which can result from chronic blood loss, inadequate dietary iron intake, or impaired iron absorption. The anemia in this patient instead is most likely a result of ongoing blood loss from colonic cancer that has ulcer. The result of the colonoscopy showed an ulcer polypoid mass in the ascending colon that is prone to bleeding. The blood gradually lost its store of iron as a result of the ongoing blood loss. Red blood cells that are smaller and less hemoglobin rich are formed when there is an iron deficit because iron is an essential component of hemoglobin. Clinical signs of iron deficiency anemia include weakness, exhaustion, and these symptoms correspond with the patient increased weakness and shortness of breath. The diagnosis of iron deficiency anemia is further supported by this patient low reticulocyte count in their blood test, which show that there is insufficient iron available to produce as many red blood cells. In addition to treating the underlying cause of this anemia, we must treat the bleeding colonic carcinoma for this type of anemia to instill restoring iron storage with dietary supplements or, if necessary, intravenous iron therapy. This indicates that the patient anemia is directly related to the long-term blood loss caused by ulcerative colonic tumor, which in turn cause iron shortage and microcytic hyperchromic anemia. To control the anemia, it will be necessary to treat the cancer with chemotherapy in addition to taking steps to raise the iron level. Next, I will explain about the pathophysiology of cardiac failure and the etiology. Cardiac failure, commonly referred to as heart failure, is a complicated medical condition that develops from any structure or physiology restriction of ventricular filling or expulsion of blood. Heart failure is caused by a number of interconnected pathways, which is mainly defined by a decrease in heart ability to pump blood, which result in inadequate blood flow to obtain the body requirements. The renin-angiotensin-aldosterone system (RAAS) and a sympathetic nervous system are two compensation mechanisms that are triggered by this deficiency. Initially, after aiding in the maintenance of cardiac output, this system eventually lead to additional myocardial injury and an increase in the oxygen demand of the heart and pathology remodeling of the heart. The remodeling process consists of hypertrophy, fibrosis, and death of cardiac myocyte. This event causes the heart chamber to shiften and dilate, eventually worsening the deterioration in cardiac function. There are many different causes of heart failure, such as disorder that directly harm the heart muscle or put more strain on the heart. Due to loss of functional cardiac tissue, heart disease is major cause, especially after myocardial infarction. Another significant factor is chronically high blood pressure, which make the left ventricle work harder and finally cause hypertrophy of heart failure. Heart failure is brought on by valve disorder such as aortic stenosis and mitral regurgitation, which overload the heart volume or pressure. Heart failure is frequently the result of myopathies, which are disorder of the heart muscle itself, which can be inherited or acquired by diabetic cardiomyopathy from alcohol misuse or viral infection. For example, arrhythmia can further worsen heart failure by preventing adequate ventricular filling, especially atrial fibrillation. Additionally, thyroid problem also can result in either hyperthermic circulation or cardiomyopathy, and diabetes mellitus, which speed up atherosclerosis and cause diabetic cardiomyopathy. Other variables that contribute to heart failure. People are obsessed and lead sedentary lifestyle are more likely to develop hypertension and ischemic heart disease, which increase the risk of heart failure. This risk is also marked increased by volume overload and hypertension brought on by chronic renal disease. In addition, the myocardium can sustain direct injury from exposure to cardiotoxic substances such as chemotherapeutic medication, and excessive alcohol intake. Heart failure management is treating the underlying causes, achieving optimal fluid balance, and using pharmaceuticals such as beta blocker, diuretic, and ACE inhibitors to reduce symptoms and enhance prognosis. In more advanced situations, heart transplant or device therapy may be necessary. Okay. That's all from me. I will pass to Hakim.
Now, I will be discussing heart failure management, focusing on medicinal, device, and advanced therapies, as well as non-pharmacological interventions. Let's begin with medicinal therapy. Medicinal therapy is essential in heart failure management. ACE inhibitors and ARBs are commonly used to lower blood pressure by dilating blood vessels, which reduces afterload and preload. While most patients manage this medication well, there are risks including hypotension and renal impairment, and also hyperkalemia. Beta blockers reduce sympathetic activity and improve left ventricular function, making them suitable for stable patients. Diuretics help alleviate fluid overload but can cause dehydration and electrolyte imbalances. Aldosterone antagonists such as spironolactone are beneficial for severe heart failure but carry the risk of hyperkalemia and renal impairment as well. New agents like ARNIs such as sacubitril and valsartan often offer better outcomes but require close monitoring. Next, let's discuss device therapy. Cardiac resynchronization therapy, or CRT, improves heart contractions in patients with conduction system disease. Implanted cardioverter defibrillators, or ICDs, are used to prevent sudden cardiac death in patients with a history of ventricular arrhythmias and markedly reduced ejection fraction. However, ICDs come with risks such as infection and unnecessary shocks. CRT is suitable for patients with symptomatic heart failure and a prolonged QRS duration, though it requires frequent monitoring and can have device-related issues. Advanced therapies include mechanical circulatory support with left ventricular assist devices, or LVADs, which provide mechanical support for those ineligible for transplantation or a bridge to it. LVADs come with risks such as infection and thrombosis and require surgical expertise and ongoing anticoagulation. Heart transplantation offers a similar quality of life for end-stage heart failure patients unresponsive to other treatments. However, it is limited by donor organ availability and requires lifelong immunosuppression. Non-pharmacological interventions, including dietary changes, increased physical activity, and weight control, are beneficial for all patients. These interventions significantly improve quality of life with minimal side effects. Patient education and self-management are crucial. They help identify early signs of decompensation and ensure adherence to treatment plans, reducing hospital readmissions. Now it's time for MCQ questions. These are the MCQ questions we prepared ourselves for you to answer. For each question, we will wait around 5 seconds and then we will reveal the answers. So for the first question is, which of the following laboratory findings is most consistent with chronic kidney disease? A. Hemoglobin 8.5 grams per deciliter, or B. Mean corpuscular volume, or MCV 72.3 FL, or C. Blood urine nitrogen, or BUN 24.3 millimolar per liter, or D. Positive stool occult blood. The answer is C, which is blood urine nitrogen of 24.3 millimolar per liter. For the second question is, what is the most likely cause of the patient's microcytic anemia? So A is chronic kidney disease, B is iron deficiency, or C, vitamin B12 deficiency, or D, acute gastrointestinal hemorrhage. The answer for the second question is B, which is iron deficiency. For the third and final question is, which diagnostic test is definitive for diagnosing colorectal carcinoma? So A is complete blood count, B is fecal occult blood test, or C, carcinoembryonic antigen, or D, colonoscopy with biopsy.